This is part 2 of 3 of head and neck anatomy. Okay, so we need to go through embryology first and talk about the face development, palate development, thyroid, pharynx, and then the pouches and grooves. Okay, so let's start with the face. So first there's going to be some swellings that lead into adult structures. So we've got a frontal swelling leading to our forehead, a medial nasal swellings, and that leads to the nasal septum and ethmoid and cribriform plates. And then the medial nasal prominences fuse to form that intermaxillary segment. And that's going to be the primary plate, which would be the median palatine process, as well as premaxilla and philtrum. Then our lateral nasal swelling will become the nose. There's also a maxillary and mandibular, and maxillary becomes the upper lip and cheek, which is the secondary palate, and then mandibular becomes the mandible, lower lip, and cheek. And so make sure that you know what these primary and secondary palates come from. Okay, so the primary palate was that intermaxillary segment, and then the palatine processes from those maxillary prominence made up that secondary palate. So these palates fuse, and they're demarcated by an incisive foramen. So it's going to grow down from the frontonasal prominences and fuse with the palate to form these nasal cavities. If there is an anomaly in forming the embryological development, then there's going to be either a cleft lip or cleft palate. So if there's an anterior malformation in the cleft palate, there's going to be a problem with intermaxillary segments. And in the primary plate, where posterior malformation is a failure of the palatine processes in nasal septum, which is the secondary plate. So make sure that you can identify anterior malformation with primary and posterior with secondary. So the thyroid is really important to talk about as far as like where it derives from. So it's becoming functional at 11 weeks, but the thyroid diverticulum is that endoderm thickening from the pharynx, and the thyroglossal duct disappears, and the remnant is the foramen cecum. So a way they could ask that is saying that, asking you what is the embryological derivative of, and then like show you a picture of the tongue. So right back there, the foramen cecum, that was where the thyroglossal duct was. And then in 50% of adults, they have that pyramidal lobe as a remnant, and you can see it right here in this picture. A thyroglossal cyst is a failure of that thyroglossal duct to close, and it's the most common congenital neck mass, and it's going to be midline. So sometimes they can trick you with one that's more lateral, and that's going to be a brachial cyst, but this midline cyst is the thyroglossal cyst. Ectopic thyroid tissue can be found anywhere along this migratory path from the tongue down to where the thyroid sits. And then congenital hypothyroidism is due to thyroid agenesis, and so that's why they check moms for hypothyroidism, because this thyroid agenesis, iodine deficiency, or mutation can cause cretinism, which is small stature, stocky, sterile, and they're also mentally deficient. Okay, you're going to need to know these arches as they go to the nerves, and then where they correspond to as far as the mesoderm and neural crest. So the first arch is going to be Meckel's cartilage, and that's going to be corresponding to the mandibular nerve, which is cranial nerve V3, and the maxillary artery goes with it. And so, as you know, the mandibular nerve and maxillary artery go to those muscles, those mastication muscles that we've talked about in the IT fossa, So we've got the mylohyoid, anterior digastric, and the tensor veli palatini and tensor tympani as well. And so the neural crest is going to be the maxilla, zygomatic, palatine, vomer, squamous, temporal, and sphenomandibular ligament. The second arch is going to be the facial nerve, so cranial nerve 7, and it's Reichardt's cartilage. And the artery is going to be the stapedial. And so just like you know with what facial does, it supplies facial expression, posterior digastric, stylohyoid, and stapedius. So the way I tried to remember this was if I knew what arch number went with the nerve, I could basically give you the mesoderm and know exactly like what they did because I knew what nerve that did and I knew what artery went with it. So like number 3, glossopharyngeal. I know that glossopharyngeal goes to stylopharyngeus, and so that's at like the greater horn and lower body of the hyoid. Cranial nerve 10, vagus, and then supralaryngeal is going to be right subclavian artery, and then pulmonary ductus arteriosus. This is corresponding with arches 4 and 6. There's no arch 5. The mesoderm is going to be cricothyroid, and levator telepalatini, and then all laryngeal except cricothyroid and levator veli palatini is going to be with 6, and that should be a V instead of a T. All right. So now we've got the pharyngeal apparatus, and so we've got pouches and grooves that are going to form a membrane, and the pharyngeal membrane 1 is going to be the tympanic membrane. So the pouch number 1 is going to be the middle ear. Pouch 2 is the palatine tonsil. Pouch 3 is the thymus and inferior parathyroid. Pouch 4 is the superior parathyroid and ultimobrachial body, and then the parafollicular cells of the thyroid. So just make sure you know what number these pouches go with and what's in each one. So if we have a developmental failure of a pouch or groove, the brachial or branchial fistula is going to be a problem with pouch 1, where a cervical cyst will be a problem with pouch 2 through 4. And so DeGeorge syndrome is a failure of pouches 3 and 4 to differentiate. And so there's no thymus or parathyroid. So this person is going to have muscle cramps from hypoparathyroidism. And then the neural crest doesn't form to the first arch. And so they're going to have a nasal or palate cleft. And then where you've learned an embryo from the heart, they're going to also have the tetralogy of Fallot. They're also going to have some problems with like infections as well. Okay, so embryology of the tongue. So there's 4 arches here too. And I know that these are hard to remember, but it's just if you keep going over them, they can get into your brain. So arch 1, we're going to have, it's going to be the tongue, and that's derived from the 1 median and 2 lateral swellings. And this is going to go to the general sensory cranial nerve V3 lingual, and then the taste chorda tympani cranial nerve 7. And the motor innervation is going to be cranial nerve 12. Arch 2 is the copula swelling, and that's going to form the oral tongue taste, which we had talked about with chorda tympani. Arch 3 is going to be the hypobrachial eminence, and that's going to be the pharyngeal tongue, the posterior 1/3 of the tongue, giving general sensory and taste, which is cranial nerve 9. And then epiglottal is going to be the swelling will go to the epiglottis, and it's giving general sensory and taste, cranial nerve 10. Okay, so now that we've moved out of that, let's talk about the PT fossa. So this is a way that you could just go back and review everything to know that you're in the room, what door you're going out, and then what's the nerves and arteries. But we're just going to go to the next slide and look at it from here. So if we're in the PT fossa, if we take one step out and we go one step anterior and we open the door, we're going to be going through the inferior orbital fissure and we're going to the orbit. So that's like our room. So then the nerves that go through here are infraorbital and zygomatic nerve, and the artery is going to be infraorbital artery. If we take a step back posterior, now we're back into the PT fossa, and now we're going to take a step medial. So medial to the PT fossa is going to be our nasal cavity, and we got there through our sphenopalatine foramen. And the nasopalatine nerve and sphenopalatine artery travel through here. If we take a step back to the PT fossa and we take a step laterally, there's not a nerve, but the maxillary artery travels through here, and now we're in the IT fossa, and we're going through there via the pterygomaxillary fissure. And that maxillary nerve is going through. So sometimes it's easy because the names are very similar. Like in the anterior, it's inferior orbital fissure. Well, we've got infraorbital nerve and artery. Okay, posterior, we've got 3 openings. So the top opening is through the foramen rotundum, and that's where V2 goes through. Through the middle opening posteriorly, we go through the pterygoid canal to get to the base of the skull, and we've got the nerve to the pterygoid canal and artery of the pterygoid canal. And then the lower posterior opening is going to be the palatovaginal canal, where the pharyngeal nerve and artery travel through, and that's going to take us to our pharynx. And then if you go back into the PT fossa and you go inferior, you're going into the oral cavity through the greater palatine canal, and the lesser and greater palatine nerve is traveling through there, and the descending palatine artery. So just go through this multiple times and make sure that you know if you go one direction or another, medial, lateral, anterior, posterior, inferior, you know where you're going to end up, what arteries and nerves go through there, and then what's the opening to get there. So here's just a big look at the PT fossa, and then right over here we've got the IT fossa. Here's this trigeminal ganglion, and then here's the V1 going up and the nerves that are traveling with it. Okay, so let's talk about the orbit. So there's a bunch of bones that are going to actually make up the orbit. We've got this sphenoid that's in pink. We've got the zygomatic. Here's maxillary. Here in blue is this lacrimal. Here's the ethmoid in the back, and then we've got the frontal at the top. So we've also got many fissures or openings. So we've got the superior orbital fissure. Number 2, we've got inferior orbital fissure, which we had just talked about with the PT fossa. We've got the optic canal. We've got the lacrimal groove, and then the infraorbital foramen. So the contents are going to be the eyeball, the eyelid, the extraocular muscle, and then the lacrimal glands. So here's our eye. So we've got this fibrous layer of sclera, which is the white portion that we can see if we're looking at somebody's eyes, and then the cornea, which is going right over, right where you would put a contact lens is where your cornea is located. And the sensory innervation comes from the long and short ciliary nerves, which we're going to learn about in a little bit. So the iris is going to control the pupil diameter, and so it's going to either let more or less light come in. So the dilator pupillae is sympathetic, and it's via the long ciliary nerves, which came off of cranial nerve V1. And so that's the sympathetic innervation to the iris. and that's going to dilate the pupil. So more light comes in. Constrictor pupillae is making the pupil smaller, and that's parasympathetic, and that's via the sphincter pupillae, and that is cranial nerve 3. The ciliary body, which is right here, is a circular muscle. It's what the lens attaches to, and it also secretes this aqueous humor and controls the thickness of the lens. So Dr. Hermy liked to call it that it's rounding up. And so the ciliary body helps with accommodation. So if you're looking at something close to you, your eyes accommodate so that you're able to read. And then also when you're in the dark, let's say driving at night, you have to have greater accommodation. And so that's what the ciliary body does. And it's constricting in response to the parasympathetics, which is coming from cranial nerve 3. And it's becoming convex, as we had said, and it's used for near vision. The corticoid is containing the vasculature, and then the neural layer is the retina. So we've got some reflexes. So as you've learned maybe in EPC, if light is shined into one eye, it's received by the optic nerve, which is cranial nerve 2. But oculomotor creates the constriction of both the pupils. So if I shine the light in my left eye, my right eye also, the pupil also constricts on the right side. The corneal blink reflex, if I touch the cornea with a piece of cotton, it looks super painful. But the sensory is going to be cranial nerve V1, and then motor, which is making me blink, is going to be cranial nerve 7. Okay, so we've got this lacrimal gland. The sensory to the lacrimal gland is going to be the lacrimal nerve. Sympathetic is deep petrosal, and then parasympathetic is going to be the greater petrosal. So I'm going to change slides so that we can see this. So tears flow from the lacrimal gland across and down to the bottom of our eye. And so this lacrimal sac here at the top, or the superior and inferior caniculus, gets these tears, and it goes to the lacrimal sac, and then it goes down to the lacrimal duct. Okay, so this is going to be the PT ganglion, pterygopalatine ganglion. And that should say ganglion on there. Right here, we've got our maxillary nerve, which, remember, this is V2. Then right here, we're going to have the nerve to the PT canal. So now let's label these canals. So right here, maxillary nerve V2 is going through foramen rotundum. And then the nerve to the PT canal came through the PT canal. So now we're going to draw this first nerve going through the PT canal, and that's going to be the greater petrosal nerve, which is cranial nerve 7. Then we're going to draw another nerve that's coming up, and it's also going to travel through the PT canal to the pterygopalatine ganglion, and it's going to continue traveling up, meeting with the maxillary nerve, and continuing on over to our lacrimal gland. And this is going to be the deep petrosal nerve. And this is from the internal carotid plexus. Okay, next, this is going to be the cell body, and it is synapsing with that greater petrosal nerve at the pterygopalatine ganglion. So it's always important to remember where the cell bodies are and where they synapse ultimately. So the cell body's in the pterygopalatine ganglion, and it's going to the lacrimal gland. And that's going to be the postganglionic. Right here, the deep petrosal and postganglionic is going to be the zygomatic nerve. And then two nerves coming off. The first one is the zygomatico-temporal nerve. And the second one has a similar name. It's the zygomatico-facial nerve. And then we've got this final nerve coming through, which is our lacrimal nerve. Okay, so let's talk about which ones are sympathetic and which ones are parasympathetic. But let's first remind ourselves, here's the internal carotid that the deep petrosal nerve is going around and forming that plexus on. Okay, so this deep blue color, our deep petrosal nerve, is going to be a sympathetic innervation. And remember, that's our flight or flight response. Then this light green color is going to be parasympathetic preganglionic, and that's that greater petrosal nerve, cranial nerve 7. The orange is going to be our parasympathetic postganglionic. Remember that joined up with the deep petrosal and eventually became, and with maxillary to become the zygomatic nerve. And then our lacrimal nerve is going to be sensory. So I think if you can draw this out, it'll help you know where everything is going, where they come from, how it gets to the lacrimal gland. Okay. So it is important to know the innervation of these muscles, and then know their anatomical action in clinical testing. So the first thing to note is SO4, LR6, all the rest 3. So SO4 is a compound in chemistry that you probably maybe remember. So that's how I remember that it goes together versus a 6 being there. So SO4, so that's superior oblique. Here it is. And that is going to be our trochlear nerve, cranial nerve 4. Then LR6 is lateral rectus, and that is going to be abducens. All the rest are going to be 3, so they're all oculomotor. Superior rectus, inferior rectus, medial rectus, and inferior oblique are all oculomotor. That's the first step. Our second step is knowing the anatomical actions. So if this is our nose, the medial rectus is drawing our eye medially. Lateral rectus is drawing our eye laterally. Superior rectus is going to elevate and bring the eye medially, adduct the eye. Inferior rectus is bringing the eye down and also bringing it in, adducting. These make sense. This part is a little hard. So inferior oblique, the way it's actually attached, it's attached the way it's attached brings the eye up and it abducts. So this is the weird part. So inferior oblique is going to elevate and abduct, and superior oblique is going to depress and abduct the eye. So that's the actions of the eye. So if they ask about that, then this is your answer. And it's like the easiest thing to do is just like draw this out on your scrap sheet of paper if you can't like reason through it. The clinical tests are going to be slightly different. So these guys just actually flip-flop. So medial rectus and lateral rectus are the same, but inferior oblique now is going to be medially, and superior oblique is going to be more medial as well. And then superior rectus and inferior rectus are going to be lateral when we do the test. Because when you're doing the H test and you bring your fingers, let's say, out and down, that is testing inferior rectus, because when we bring it out, that's going to be lateral rectus. So the only thing that is going now down would be the inferior rectus. So it's just locking out all of the other muscles, and that's why the clinical test looks a little different than the anatomical action. But just make sure that you're able to draw both of these out. Okay, so here's this inferior oblique. It's attaching laterally and pulling and going underneath inferiorly and pulling up. And so that's why it elevates and abducts, where there's intorsion with the superior oblique. And you can see them as they attach here. So here's the levator palpebrae. That's the first one, and that's going to be elevating, opening our eyelids. And then under it, we've got superior rectus, so we've got middle and lateral rectus. And here is our optic nerve, which is a favorite to tag on the practical. Okay. So we can see all of the different parts here. And you can go through these and make sure that you know where all of these muscles are. So nerves of the orbit. So we've got cranial nerve V1, and that's going to be ophthalmic nerve. And we've got the frontal nerve and the lacrimal nerve coming right here. So here's the lacrimal nerve. Here is the frontal nerve. And this is going to be supraorbital, and here's supratrochlear. And then over here, going to our superior oblique is going to be cranial nerve 4. Here's our ciliary ganglion, and remember that is what cranial nerve 3 goes through, and then the short ganglion is the postganglionic that come off of that. So here's the short ciliary. And here is the long ciliary, which is the sympathetic. Here's the parasympathetic. And then nasociliary goes more toward the nose. Some of these are harder to find in lab. And here are these located on a cadaver. Here's the ophthalmic artery right here, and remember that's coming off of our internal carotid, so they have to pull back some of this dura, and it's just that tiny little artery coming off, and it's going toward the eye, and that's something they like to tag on the practical. Okay, clinical eye correlates. So strabismus is when the eye doesn't focus at the same time, and so this medial strabismus could be because the lateral rectus doesn't work anymore, so it can't pull the eye laterally. Ptosis is going to be a drooping of the upper lid, and that's usually due to that weakness of the levator palpebrae, which is innervated by cranial nerve 3. And then papilledema is on the retina, and looking at the ophthalmoscope, so you can see this normal pretty optic disc, and you can see that it's kind of blurry. And that could be due to like a hematoma, hydrocephalus, where there's too much CSF in the head, like in the skull, or like a tumor. So there's no change in the visual acuity, but they're going to have a blind spot in their visual field. Here's looking at an MRI. And so here's the pons, here's the cerebellum. Right here is our basilar artery that's going down the middle of our circle of Willis. There's that optic nerve. Here's medial rectus. There's lateral rectus. And then right here is our internal carotid artery. There's our fourth ventricle, and there's some ethmoid air cells. Okay, let's go ahead and talk about the ear. So it's important to know the external ear. What's the innervation? So it's got 3 different innervations, and one way you can remember it is lag. So L-A-G, starting at the helix, going around to the front and down to the lobe of the ear. So we've got the lesser occipital that's going to be on the more posterior side. Anterior is going to be auriculotemporal from V3, and then great auricular is going to be our earlobe. The blood supply is going to be from the external carotid, which is the superficial temporal artery and posterior auricular artery. The external auditory meatus is going from the auricle, which is like the external ear, to our tympanic membrane. So the first third is going to be cartilage, and then it's going to bone, and it's going to have a sensory innervation of auriculotemporal. And as you can see in this picture, like the hole that goes back into our ear is innervated by auriculotemporal, and all of that back through there is auriculotemporal, and then some vagus. So this cauliflower ear is auricular hematoma, and so like sometimes wrestlers can get that from a injury over a period of time, and the force is going to separate the perichondrium, which is vascular, from the auricular cartilage, which is avascular, and it can end up looking like this cauliflower ear. Otitis externa is just an external ear infection or swimmer's ear. So our tympanic membrane is going to be innervated by 3 things. So we said auriculotemporal was the front portion of our ear as well as our canal, but it's also going to get our external TM as well. So auriculotemporal, facial, and vagus provide sensory innervation for the external TM, and the internal TM is coming from the glossopharyngeal nerve, cranial nerve 9. And so make sure you know those nerves. The middle ear, it's got our ossicles, the malleus, incus, and stapes. And the malleus is what's attached to the tympanic membrane. And then we've got our pharyngeotympanic tube, which is also our eustachian canal, and it's connecting that tympanic cavity and the nasopharynx, equalizing the pressure. Muscles reducing ossicle vibrations to dampen sound are the stapedius and tensor tympani. So the stapedius is innervated by cranial nerve 7, which is facial, and then tensor tympani is innervated by cranial nerve V3. Okay, so you can look at this and review the gross anatomy. Okay, so the inner ear is going to be, there's going to be different functions. We've got auditory and vestibular. So auditory, of course, is going to be converting sound waves to action potentials, and vestibular is going to be sensing gravity and head movement. So for example, like somebody being dizzy is going to be a problem with their vestibular function. The most important of these to know would be acoustic neuroma, and that's going to be a tumor of the vestibular nerve, and it's usually in that internal acoustic meatus, which could also affect the facial nerve. So you're going to have all of those problems with movement of the face, or problems with like chorda tympani, anything that the facial nerve does, you're going to have problems with that as well, and then also deafness. Okay. So we've got semicircular canals and then the vestibules as part of the vestibular portion of the ear. So the semicircular canals have 3 ducts, and they have cristae, which are the sensory portion, and then the cupula is deformed by the endolymph causing the cilia to bend, and it's sensing rotation. So know that the semicircular ducts have cristae sensing rotation. The vestibule has the utricle and saccule, which have the maculae with otoconia, which is calcium crystals, sensing linear head rotation. Sensing linear head movement. The cochlea, the sensory region, is the organ of Corti, and it's sensing pressure waves as it vibrates the basilar membrane, causing the hair to bend. So low vibrations are going to be on the apex of the membrane, and high frequency vibrations are going to be found at the base. So make sure that you know that low is associated with apex and high with the base. So the transmission of sound, we first collect sound waves through our ear. The middle ear converts them to vibrations as the sound waves hit the tympanic membrane and sets off a chain reaction. And then the inner ear, the hair cells convert it to action potentials, and the stapes contracts with the oval window so that the vibrations travel up the scala vestibuli toward the helicotryma, and then the portion of the basilar membrane is vibrated, and the hair cells at that portion convert it to action potentials, which travel down the scala tympani and are released at the oval or at the round window. So we start at the oval, we end at the round in the inner ear. And that's all I have for today. So thank you.